Alrighty, Margie, take it away.
Good afternoon, everyone, and welcome to this medication safety webinar. My name is Margie Giuliano, and I'm the Regional Med Safety Lead for the New England QIN-QIO, and I will be your facilitator for today's webinar. Today we'll be discussing how we need to get smarter about using antimicrobials across the care continuum. We have a great panel of speakers to help us get there. Before we get started, I'm going to quickly review a few housekeeping items. The call will be recorded, and the recording will be available within a few business days on our website. Phone lines will be on mute while the speakers are talking, but we will unmute the lines after the last presentation for questions, and I'll give some instructions on how to ask questions at that time. Although the lines will be muted, we will still want you to actively participate during the session by using our chat function. My colleague, Alyssa DeCuna, the Antibiotic Stewardship Lead in Massachusetts, will be monitoring the chat window and responding to your comments in real time. So don't be shy. We'd love to learn more about your efforts and how we might best support you going forward. And we'd also love to hear your thoughts about what the speakers are saying. So let's get started by using chat right now and seeing who's on the call. Please type in your name and role in the organization that you're representing and the state that you're coming from. Sorry, the slides are a little delayed. Bear with us. While you're doing that, it's important to note that today's speakers have no conflicts of interest to disclose. Today's speakers, I've already introduced myself. We also have with us Dr. Shira Doron. Dr. Doron is in the Division of Infectious Diseases at Tufts Medical Center. She has been the physician head of the Antimicrobial Stewardship Program there since 2005 and is also the Associate Hospital Epidemiologist. On a national level, Dr. Doron serves on the Society for Healthcare Epidemiology of America Antimicrobial Stewardship Subcommittee and the Infectious Diseases Society of America Antibiotic Stewardship and ID Leadership Working Group. In Massachusetts, Dr. Doron has been involved in several statewide initiatives to improve the care of patients with suspected or confirmed infections. Dr. Doron has numerous publications related to antimicrobial resistance and stewardship. We also have with us Beaulac, PharmD. Dr. Beaulac trained at Massachusetts College of Pharmacy, completing postdoctoral training in infectious diseases at Hartford Hospital. She is the pharmacist head of the Antimicrobial Stewardship Program at Tufts Medical Center, as well as the infectious diseases pharmacist for the institution. Dr. Beaulac is involved in the Massachusetts Society of Health System Pharmacists, the Council of Boston Teaching Hospitals for Pharmacist Education, and the Society of Infectious Diseases Pharmacists. Her research focus is in methods of optimizing antimicrobial use.
Emily from WebEx, are you on the line right now? If you are, if you could move the ball to Morgan Gargiulo. Emily, are you on the line?
Yes, I'm here.
Emily from WebEx, are you on the line?
Yes, can you hear me?
So until we get the folks from WebEx to change the presenter, we unfortunately cannot advance the slides right now. So Margie's going to go ahead and go over the learning objectives while I work to get in touch with the WebEx folks.
Hi, Emily's here. Who needs the ball?
Can you pass it to Morgan?
Yes. Sorry, I was on mute.
Thank you.
Okay, so our learning objectives for today are to identify why antibiotic resistance is considered a nationwide threat, to describe the relationship between antibiotic use, drug resistance, and C. difficile, explain what an antibiotic stewardship program does and its benefits, identify key members, infrastructure, and activities necessary to successfully execute an antibiotic stewardship program, and state why antibiotic stewardship must be addressed across the continuum of care. For those of you who have not been involved in antibiotic stewardship over the past several years, the possibility that there could be a future in which common infections were not treatable maybe seem more like a science fiction story versus reality. We now know that we do have bacteria that have developed resistance, and these bacteria threaten the lives of many vulnerable patients. The actions of the past will haunt us for a long time until we address the issue head-on and really start to change culture. This extends to changing the culture for patients as well. One of our biggest challenges is assuring patients that they may not need to have a prescription in hand for an antibiotic when they go to one of our outpatient settings to be treated for a cough and/or fever. According to the CDC, antibiotic resistance is now a public threat and a global issue. With ongoing antibiotic stewardship work in the hospitals and nursing homes across the country, the CDC most recently included the outpatient setting as a focus area and published guidelines for management of antibiotic use in this setting. In the United States, approximately 60% of antibiotic expenditure for humans is related to care received in the outpatient setting, and about 269 million antibiotic prescriptions are dispensed from the outpatient pharmacies annually. While about 30% of these prescriptions are unnecessary, 50% of outpatient prescribing might be inappropriate. This includes drug selection, dosing, duration, and unnecessary prescribing. Complications associated with antibiotic use include an increase in emergency department visits due to adverse drug events, that's approximately 143,000 annually, and increased risk of C. difficile infection. The outpatient setting needs attention if we want to combat and subdue this threat. The White House National Action Plan for Combating Antibiotic-Resistant Bacteria aims to reduce inappropriate antibiotic use by 50% in the outpatient setting by 2020 through antibiotic stewardship programs. Inappropriate antibiotic prescribing and use can lead to devastating patient outcomes. According to the CDC, at least 2 million people in the United States are infected with antibiotic-resistant bacteria, and at least 23,000 people die each year. The CDC, in expanding its focus to the outpatient setting, is encouraging all outpatient providers and practices to implement its outpatient core elements, a framework for antibiotic stewardship. This will be explored in more detail by our other speakers. So in order to achieve this goal, we need a community solution. We know this work has already begun. Antibiotic stewardship programs are pretty well entrenched in the acute care settings, and we know that the nursing home or long-term care facilities are developing protocols and antibiotic stewardship programs to address this issue as well. Several nursing homes are currently engaged in this effort with the Quality Improvement Organization, utilizing resources and tools for training and educating staff to assist in implementing a program. But these settings are not enough. To make a difference, we need to expand to the location that has the most prescribing. We need to include outpatient care settings. This slide provides a list of the different providers and care settings we are hoping to engage in this effort. For each of them, there may be different reasons why they may want to collaborate, but whatever the reason, it isn't a heavy lift. It's the right thing to do for the patient, and it aligns with other efforts that you may already be involved with. For primary care clinics and clinicians, we know that engaging in antibiotic stewardship can assist in their mandate under CMS's new Merit-Based Incentive Payment System, or MIPS program, which requires them to be engaged in an improvement activity. So this could count as a medium weight improvement activity. For emergency departments, we know that adopting CDC's outpatient antibiotic stewardship recommendation aligns with both the Joint Commission and CDC's antibiotic stewardship programs in the hospital inpatient setting. Other partners we're hoping to engage include outpatient specialty and subspecialty clinics, retail health clinics, urgent care clinics, and the larger healthcare systems, of which many of these settings may be part of a network, like FQHCs, physician practice groups, and accountable care organizations. The New England QIN-QIO team can help by providing guidance, expertise, and program materials to advance appropriate use of antibiotics in your setting. You can participate in learning and action network activities such as this that promote and spread best practices in antibiotic stewardship in the outpatient care setting. All that being said, we each have to do our part in engaging patients and families in this ongoing crisis. It's important that we all lead by example. It starts with us so that we can educate and spread the cure for a challenging issue. I'm now going to turn over the program to today's speakers to explore more. Dr. Doron?
Thanks, Margie. So I'm thrilled to be here today to speak to such a diverse group of providers across the continuum of care. And we're talking about getting smart about antibiotics. I think I probably don't need to tell the people on the line today that we're in a global crisis and that resistance is obviously a very big public health issue with bugs that are becoming harder and harder to treat. Over the years, I have been giving talks on this topic, and I ask audience members to raise their hand if they've seen a patient who has a bug that's so resistant that there are no antibiotics left on the market to treat their infection. And over the years, I find that more and more people raise their hand in response to that question. And so I think everybody has probably heard of or seen patients like this. These are some of the trends over the years regarding antimicrobial resistance with the first-generation cephalosporin resistance on the left and carbapenem resistance on the right. You can see how steep that rise is, and that is obviously very scary, with carbapenem being one of our last-line agents for resistant gram-negative infections, and these graphs represent Klebsiella resistance. We wouldn't really care about developing resistance if we were able to keep up with that resistance with our drug development. But the fact is that as resistance becomes a bigger and bigger problem, antibiotic development is not keeping up, and these are the numbers of new antibacterial drugs approved over the years in 5-year increments, and you can see that it seems to be dwindling, and so what we can say is that the drug development pipeline for antibacterials is really drying up. As a response to that, the CDC put out its first monograph called Antibiotic Resistance Threats, and it's based on data from 2013 in the United States, and they categorized the threat levels of various types of resistant organisms. And they also generated some scary statistics that at least 2 million, almost 50,000 patients had illnesses due to antibiotic-resistant bacteria and antifungal-resistant fungi, with 23,000 deaths. When you think about that number is higher than the number associated with homicides, significantly higher than the number associated with motor vehicle accidents, is on par with what we're seeing these days in terms of the 23,000 deaths you see there in terms of deaths related to the opioid epidemic. And specifically thinking about C. diff, which we'll talk about a little bit more, we're seeing at least 250,000 illnesses due to C. diff in a year and 14,000 deaths. So a very significant public health concern, and the CDC divides these into urgent, serious, and concerning threats. And you can see that some of the organisms in these lists, particularly in the urgent and serious threats, are what we're talking about today, are the ones that can be dealt with, or the emergence of which can be decreased by prudent antimicrobial use, by interventions by antimicrobial stewardship programs. The WHO also has released its priority list, actually just very recently, less than a month ago. And they have different organisms in the different categories of its list. And so here you can see their priority 1 critical in all 3 cases are carbapenem-resistant gram-negative infections. And this is its priority 2 or high threat list. And this is its priority 3 or medium threat list. I'm going to turn this over for a few minutes now to Shira. And Shira's going to have me advance the slide, so you will hear her say next slide. So Shira?
Yeah, so, the idea of pathogens developing resistance is not a novel concept. Andrew Fleming even acknowledged this in his 1945 Nobel Prize acceptance speech, saying that it's not difficult to make resistant to penicillin in the laboratory by exposing them to suboptimal concentrations. And this does happen in the body.
Shira, did we lose you?
Sounds like we lost Shira.
We lost Shira, I think.
Oh, Shira, sorry.
Yeah, she faded out. Maybe she went on to mute.
Shira, make sure to press #6 to unmute your line, just in case you haven't done that yet.
Hello?
We can hear you now.
Hi, this is actually Kelly McLaughlin from Devereaux. Can you hear me?
Yes.
Okay, I'm sorry I was late getting in.
If you can just go ahead and mute your line,
Shira,
that would be
sorry,
great.
something happened where my call dropped.
Okay.
Okay, Shira, you're on collateral damage.
Okay, so just kind of say, even back in the 1940s, we realized that the inappropriate antibiotics actually led to death, and we needed to keep up with wise antimicrobial use to prevent the damage from those inappropriate uses. Not only do we know that the one antibiotic leads to resistance for that antibiotic, we also know that there's a phenomenon called collateral damage, where the use of common antibiotics can cause resistance to that specific antibiotic, but because of the selection of resistant mutants, but it can also cause resistance to other antibiotics through disrupting the ecology and potentially selecting multi-drug resistant organisms that can then overgrow within the host microbiome. Once we know that the host defenses have become suppressed, these multi-drug resistant colonizers can become multi-drug resistant pathogens, and that creates this vicious cycle of needing broader and broader antibiotics and then causing more and more resistance. So the use of cephalosporins, which we think of as safe and effective drugs, have been associated with the development of VRE, MRSA, ESBLs, as well as multi-drug-resistant Acinetobacter. And conversely, fluoroquinolones, which are used nearly ubiquitously, have also been associated with MRSA, fluoroquinolone-resistant gram-negative, as well as ESBLs. Next slide, please. And we've seen the impact of antibiotic use not only affecting patients, not only affecting bugs in the lab, but it actually affects patients. It doesn't just affect, the broad scope of bugs that grow, but we've seen that actually patients who have been exposed to antibiotics in the recent past have a statistically significant higher likelihood of developing a subsequent multi-drug resistant infection. This has been shown consistently in various studies, and it's something that it's not just an epidemiologic trend, it's an actual patient safety outcome that we need to be cognizant of. Next slide, please. And here, as I'm harping about how antibiotics are so horrible, I can't not talk about C. diff. C. diff is virtually exclusively occurs in patients who have been exposed to antibiotics. As patients are exposed to antibiotics, their flora gets disrupted, and it takes the absence of antibiotic selection pressure for their flora to regrow. During that time period where a patient's normal flora has kind of been downregulated and killed off, that promotes the optimal conditions for C. diff to overgrow, produce toxin, and cause significant disease to the patient. We all know that C. diff not only causes discomfort to the patient, but it actually has a pretty heavy morbidity and mortality burden and can really impact the patient's life going on for years to come. Next slide, please. Another significant consequence of antibiotic use are the adverse effects associated with it. It's been estimated that 4 in 1,000 patients visit the ED each year just for some sort of adverse drug reaction, and 1 out of 5 of those is due to an antibiotic. In fact, antibiotics represent the largest group of, or the largest group of drugs that cause patients to seek care for adverse drug reactions. 27% of these ED visits result in hospitalizations, and so there's a lot of healthcare utilization associated with antibiotic use. And as we're thinking about, sending people to the hospital more, sending patients to ED more, we have to think about, were those antibiotics even necessary in the first place? And, was it worth putting the patient at this additional risk for harm? Next slide, please.
We want to do a quick remute of everybody's lines. Alyssa?
Sure, I can do that. Hold on 1 second.
The leader has unmuted your line. The leader has muted your line. To unmute your line, press #6.
All right, everyone should be remuted, but if our speakers could again press #6 to unmute yourself, that would be great.
Okay, so as I've just kind of created this horrible picture of what antibiotics are, that's where I'm going to kind of sell you on antimicrobial stewardship, which is defined as an activity to optimize antibiotic appropriate selection, dosing, route, and duration of antimicrobial therapy. The overarching goals of stewardship are to attenuate and potentially even reverse antimicrobial resistance trends, to prevent antimicrobial-related toxicity, and that not only includes the adverse drug events, but then can also kind of be extended to the associated healthcare infections like C. diff and other toxicities. And lastly, a goal of antimicrobial stewardship is to reduce the costs associated with this inappropriate care. Next slide, please. So, focusing on cost, that's the easy sell for antimicrobial stewardship, but there are a lot of benefits that come along with having an antimicrobial stewardship program and enforcing antimicrobial stewardship principles. Next slide, please. So the financial savings have been proven short-term and long-term in pretty much every care setting that has been studied. Inpatient, outpatient acute care, long-term acute care, in various outpatient clinics, all of these different settings are able to actualize a financial savings by having an antimicrobial stewardship program in place. But then there's the other quality of care benefits that we get from these programs as well, including decrease in resistance, minimizing adverse effects, and decreasing superinfections and C. diff. Next slide, please. The IOM estimates that the annual cost of superinfections or drug-resistant infections that come from as a consequence of antimicrobial use is about $4 to $5 billion a year. So it places a really heavy burden on our healthcare system. We have seen that the implementation of an antimicrobial stewardship program is not only able to stop resistance trends that may be alarming, but also they're able even to reverse certain trends. Here we were able to see that an antimicrobial stewardship program at a local Massachusetts community hospital was able to kind of stop and reverse a trend of multi-drug resistant Enterobacteriaceae. And this, along with this program, it was a sustained benefit. It wasn't just a single blip, but they were able to really change the course of history. And this has been shown in various settings as well. Next slide, please. As I talked about adverse drug reactions, there's a lot of things that antimicrobial stewardship programs can do to mitigate the risk of antimicrobials. Part of that includes encouraging not using antibiotics when they're not necessary, as well as using, if antibiotics are necessary, using antibiotics that are safer and potentially less likely to be causing adverse drug reactions. Compliance with consensus guidelines is generally encouraged and enforced by antimicrobial stewards and tends to encourage optimizing patient safety within the guidelines of clinical care. Deviations from established guidelines has been proven to cause multiple adverse drug events, including all of the adverse effects that come from inappropriate and unnecessary treatment of asymptomatic bacteriuria. There have been patients who have had potentially fatal arrhythmia due to the inappropriate use of fluoroquinolones. And there was a case series of patients who developed life-threatening hemolytic anemia due to inappropriate prolonged beta-lactam therapy. So all these drugs that we use all the time and we think are generally safe, when used inappropriately, can compound the risk of adverse drug reactions and potentially negative consequences downstream. Next slide, please. Another facet that antibiotic stewards tend to encourage is not only avoiding adverse drug reactions, but that also includes avoiding allergies. A local hospital in Boston was able to implement a educational initiative surrounding antibiotic allergies, including knowing when penicillin testing was appropriate, knowing whether or not it was appropriate for certain patients, and knowing what antibiotics are likely to cross-react with the penicillin. This educational initiative was able to provide actually very significant improvements in provider knowledge about how to treat patients with penicillin allergies, and therefore really help mitigate some of the risks that can come with giving an antibiotic to a patient with a penicillin allergy. Next slide, please. And then bringing it to C. diff, which we know is a huge issue for everyone across multiple settings. If you look at the bottom graph you see at Carney Hospital over in Dorchester, they were able to, using targeted antibiotic surveillance and intervention, they were able to decrease their incidence of C. diff by 60%, just by decreasing their targeted antibiotic use by 23%. Comparatively, if you look at the top figure, there was a hospital in Pennsylvania that implemented several infection control measures to try to mitigate the climbing rates of C. diff, and they really weren't able to make a ton of headway. However, once they added antimicrobial stewardship measures to their strategy, they were able to actualize a significant decline in their C. diff rates that really closely mirrored their decrease in antimicrobial use. Next slide, please. And we know that not all antibiotics have the same risk of C. diff. So in Scotland, there has been this concerted effort to selectively or discourage the use of drugs that are more highly associated with C. diff. They have an acronym called the 4 C's. So Cipro, clindamycin, cephalosporins, and coamoxifab, which for us is augmentin. By limiting those 4 antibiotics, they were able to really, really impact what was viewed as a rising trend and something that was going to be really challenging to overcome. They were able to reverse this trend of increasing C. diff. Next slide, please.
Okay. So I think Shira has really framed the problem. And so let's talk about some of the solutions for the people on this call. So the CDC, as Margie mentioned, has developed its core elements of antibiotic stewardship. And those core elements are what everybody should be thinking about and hopefully in the process of implementing. It's a framework really to think about the structure of an antimicrobial stewardship program. It obviously is very broad and doesn't get at the specifics, but every institution or facility needs to start with commitment, a demonstration of dedication to and accountability for optimizing antibiotic prescribing and patient safety. And we'll talk about that in more detail. Any stewardship program needs to have some kind of action for policy and practice. So to have a program, you need to be implementing at least one policy or practice to improve antibiotic prescribing. You need to be assessing whether it's working and then modifying it as needed. If you start with one, the rest will follow. And it can be hard to come up with that one, and we're here to help with that. And tracking and reporting is important. So monitoring antibiotic prescribing practices, offering regular feedback to clinicians, having clinicians perhaps assess their own practices if you don't have the technological infrastructure to do that monitoring in another way. And then finally, education and expertise. So providing educational resources to your clinicians and to your patients on antibiotics and ensuring access to needed expertise and optimizing antibiotic prescribing. And that may be the biggest challenge, that needed expertise. We realize that not every one of you has access to an infectious disease physician, an infectious disease pharmacist, and that's where partnering is going to be really, really key, and we'll talk more about that. So if you haven't seen it already, I encourage everybody to go to the CDC's Get Smart website. That's where the core elements are, and that's where there are materials, guidelines, educational materials for providers and patients. So this is the main Get Smart page. You can see there that there are sections for doctor's offices, healthcare facilities, and even farms. This is the core elements of outpatient antibiotic stewardship, and there are a lot of materials in here, as you can see. This is the site for the core elements of hospital antibiotic stewardship programs. Again, there are lots of resources here. And then this is the section for the core elements of antibiotic stewardship for nursing homes. So let's get to the nitty-gritty. You're going to need to build your team. Your stewardship team is going to carry out all of the elements of your stewardship program. Now, you can't build a team until you have buy-in. You need buy-in from leadership. You need buy-in from the people who are going to be experiencing the restrictions and the guidelines and the protocols and having to follow them. So from the top to the bottom, you need buy-in, and that may involve you sitting down with somebody over coffee, you bringing, somebody lunch and bringing in an expert to do education. But before you try to make any new rules, buy-in is key. That means your Pharmacy and Therapeutics Committee, if you're in the acute care setting, your practice managers in the outpatient setting, your hospital or health system administration, your medical staff leadership, and any local providers that are going to be affected, acute care providers, primary care providers if you're doing something in the outpatient setting, specialty, subspecialty clinics, EDs, urgent care, long-term care. These are all areas where stewardship should be implemented, and so you need to get buy-in. So who are going to be your key players? In the ideal world, your key players are an infectious disease specialist and an infectious disease pharmacist. The infectious disease specialist coordinates the policies and procedures and serves as a liaison with medical staff, and the pharmacist executes and manages those policies and procedures and is responsible for reporting, monitoring, and surveillance. Again, I realize not every one of you has access to these specialists, but we'll talk about how you can gain some access and utilize resources. Now, those two are necessary but not sufficient. You need a number of expert resources to create an antimicrobial stewardship program. Infection preventionists are going to be involved, other medical specialties, your quality and patient safety staff in the acute care setting, your microbiology lab staff, other clinical pharmacists, and the more you can involve your IT specialists, the better. Shira?
Sorry, I was just unmuting. Okay, so to kind of piggyback on what Shira was saying, we recognize that not everybody has access to the ability to have specialists on hand all the time. But it really is important when you're having authorized personnel that they really have that background in infectious diseases to really be able to really wisely manage the use of antibiotics. When a hospital tries to use a chief resident to be the person to authorize
the last year again. Uh-oh. Why don't I want to...
Yeah, can you continue her side?
Yes. What Shira was saying is that there have been studies that showed that using an infectious disease attending or infectious disease pharmacist compared to either an ID fellow or someone who is not at an attending or staff level does not result in the same degree of cost savings or decreasing of antimicrobial usage. And so that needs to be taken into account. This slide as well shows that non-specialized clinicians can be effective in stewardship.
Sorry about that. My call keeps dropping. Yeah, so as Shira was mentioning, not having those specialists are really important to being able to have an effective program. However, not everybody has a full-time ID physician and a full-time ID pharmacist at their fingertips. And there are multiple centers that have been able to leverage their own staff by just having a small partnership with some specialists. So Abraham McKinnon Hospital, a small hospital in South Dakota, it's a mid-sized community hospital. They had 20 hours of rotating pharmacists and pharmacy students and residents. And remember, students are always free. But really, all they needed was 3 hours of the ID specialist time, 3 hours a week to round on 56 mentored beds. And by using just minimal resources, they were able to make a total of 554 interventions, of which 379 were accepted, and if you notice, the vast majority of those are discontinuation of antimicrobials. So they were able to, with minimal resources from a specialist, really have a big impact. Conversely, Green Memorial Hospital down in Georgia had a rotation of non-ID, general pharmacists that worked with an ID physician to recommend interventions, and they were able to actualize thousands of dollars in cost savings by decreasing their use of many broad-spectrum antimicrobials like ceftazidime, imipenem, zosyn, and vancomycin. Next slide, please. So the ability to improve antibiotic use, it doesn't happen magically, it doesn't happen overnight. It requires a lot of time, effort, dedication, and a few key ingredients. So having dedicated staff, ideally with some level of specialty in there, being able to impact the chain, the culture of prescribing, and including by providing education to your prescribers about antibiotic use and how to optimize that, and then feeding that information back to them by using appropriate benchmarks and metrics to inform your prescribers about how they're doing both in their prescribing and also the downstream impact, looking at antimicrobial resistance. This is where we encourage leveraging the microbiology laboratory as well as the use of technology and informatics. Next slide, please. So here I have some examples of some data mining tools that are able to identify patients who are on certain antimicrobials. Now, this one's relatively sophisticated, that it incorporates things like combinations of antimicrobials, or it only flags when patients have been on antimicrobials for a certain number of days. And if you can you hit the next slide? There are other data mining tools that also can incorporate lab values. So if a patient is on a high-risk antimicrobial and has a change in their renal function, there's different flags. These are pretty highly advanced technological tools, but there's even some kind of lower-tech technology tools that can still be highly effective. Just running a list of everybody that's on drug X on that day can still be a useful way to utilize your electronic medical records or your electronic pharmacy system to identify who is your captive audience, who are the patients that potentially warrant some level of intervention. Next slide, please.
One very effective way to drive your antimicrobial use in the right direction is by implementing guidelines and protocols. What we're showing here is one from our hospital, and obviously it looks fairly complicated. But the point is that the more you standardize, the more you're going to have antibiotic use fitting the national guidelines, which results in narrow-spectrum agents being used where they're warranted, broad-spectrum agents where they're warranted, and ultimately more appropriate antibiotic use throughout. So this is our treatment algorithm for hospital-acquired, ventilator-associated, and healthcare-associated pneumonia. And you can see that the first thing the algorithm tells the clinician to do is get that lower respiratory tract sample. Because without a culture, it can be very hard to de-escalate to narrower spectrum antibiotics. And then, right after that, is performing your risk assessment for multi-drug resistant organisms in order to initiate empiric therapy. So the most important thing that we are teaching our fellow clinicians here at TUPS every day is some patients are at risk for multi-drug resistant organisms, and therefore they need broad-spectrum empiric coverage, even without culture data. But other patients are at much lower risk and need to be treated right off the bat with narrow-spectrum antibiotics. And so you can see that in this algorithm here, we ask a number of questions related to multi-drug resistant organism risk. And these different risk factors come from a variety of different studies from the literature. And so we ask, does the patient have a new pneumonia that developed in the hospital? Otherwise, it's not a hospital-acquired, but it would be then considered a community-acquired pneumonia, which would be a different pathway. And do they have one of the following? Their current hospitalization is long, they've been on antibiotics, they're immunosuppressed. If yes, they go right to our broader spectrum coverage. If the answer is no, we have another series of questions for sort of lower risk things. And essentially, if the patient doesn't meet any of those criteria, they get order set A, and we're not showing it here, but order set A looks just like a community-acquired pneumonia regimen, and then order set B and C are for the not so sick and sicker patients, and it's 2 or 3 broad-spectrum agents. We also have what happens on days 2 and 3. You're checking your cultures, you're checking the patient's clinical response, and then different scenarios, whether cultures are positive or negative, whether the patient's getting better or not better, and then what to do then. Should you de-escalate the antibiotics then, and how long to treat? So all of that is bundled in to this rather complicated guideline. But guidelines are one thing. The thing that's really effective is physician order entry order sets that make the right choice, the easy choice. And here's our order set for Clostridium difficile treatment. And so if you can see that, first of all, there is a link to the C. difficile protocol, which would look, like the pathway we just showed you for hospital-acquired pneumonia. But here is where your treatment options are. And we've expanded things a little bit so you can see that, if you're treating a severely ill patient, there are 3 options. The patient's severely ill with hemodynamic instability, they're severely ill with signs of ileus, they're severely ill with toxic megacolon, or they're not severely ill here. And when you click on any of those radio buttons, you will only get the appropriate antibiotic option for that clinical scenario. And so if you make the right antibiotic the only antibiotic that the clinician can choose, then you've sort of won half the battle right there. Studying the impact of your protocols can teach you a lot about what's working and what's not working as you roll out various interventions in your program. This was a study from 2008 where we looked at the impact of the very first version of our ventilator-associated pneumonia protocol, which is different than the one that we're showing you now, but it was the first one we'd ever had, and it was after the 2007 national guidelines on treatment of ventilator-associated pneumonia were released. And you can see that when we looked at pre-protocol in the white bars versus post-protocol in the black bars, we had statistically significant increases, obviously, in the appropriateness of initial empiric antibiotic therapy per protocol. Well, of course, clinicians are going to be using the protocol antibiotics more often after the protocol is rolled out, although this pre-protocol time was in a time post-national guideline. So that does just sort of show you that just because a national guideline comes out doesn't mean that people are following it. We also had a statistically significant increase in the appropriateness of de-escalation of antibiotic therapy, whether you looked at it per patient or per opportunity for de-escalation. We also saw a significant decrease in intravenous antibiotic use after the protocol was rolled out, and all antibiotic use, and trends towards decreased ICU stay and hospital stay. Shira mentioned leveraging your microbiology lab, and that includes asking the microbiology lab to generate, at least annually, an antibiogram. For those of you who haven't seen an antibiogram, this is what an old tough antibiogram looks like. And the way they're set up is the organisms are along the left-hand column, and across the top you have all of the antibiotics. And so these are all of the organisms that were isolated with any frequency in our microbiology lab in a year. So some of them, like E. coli, we see a lot, 470 times. Others, like Enterobacter or Acinetobacter, we don't see as many of, luckily. And across here you see all of the antibiotics, but each one was tested against. So some are not applicable, that's not on the ampicillin, not on the panel for Acinetobacter. But where you see a number, that's the percentage of times that isolate was susceptible to that antibiotic. And this can really be helpful in a number of ways. It can be helpful in choosing empiric regimens when you do have the organism, but not yet the susceptibility information. It can be helpful in following trends in resistance over time to see if your antimicrobial restrictions and protocols and decreasing that antimicrobial usage has impacted the antimicrobial susceptibility. And we have seen that over time, where we've decreased ciprofloxacin practice and usage over time, we've seen some increases in E. coli susceptibility, and we actually break out urine E. coli from the emergency room and urine E. coli from our general medical clinic, and the fact that we're seeing susceptibility rates in the mid 80s is actually a great improvement over prior year. The antibiogram is also generated on the gram-positive side.
So I see from the comments, some concerns that a lot of what we're talking about has to do with inpatients, but it really can be applied in all care settings, and that's really important because our patients are all the same patients. Next slide, please. A patient may come into an ED, which then leads to being admitted to an acute care facility, and then, they get better, but not completely, need to go to a nursing home. Then as they continue to get better, they may need to be seen in some sort of, clinic and potentially need some sort of have to go to some outpatient treatment facility. And the same patients are going from place to place to place and spreading these bugs everywhere. So it's important that we all work together using the same principles to optimize antimicrobial use, which can then improve care for that same one patient and also decrease the development of resistance and the spread of resistance from that patient to other patients in each of our unique settings. Next slide, please. So what the CDC has looked into the impact of each individual facility trying to do some sort of antimicrobial stewardship intervention as opposed to no intervention, and that does help decrease the prevalence of resistant organisms. But what they've found is that by coordinating this approach and having facilities work together has an exponentially better impact on preventing the spread of resistant organisms. With immediate nationwide infection control and antimicrobial stewardship interventions, they estimate that we could prevent over 500,000 healthcare-associated infections from carbapenem-resistant Enterobacteriaceae, multi-drug-resistant Pseudomonas, MRSA, and CTE, just over the course of 5 years. And when you compare that with independent efforts, this coordinated attempt could result in a cumulative reduction of 74% when you go nationwide compared to just a small network. And over the more years over which this is spread, the greater and greater impact this has. So kind of like compounding interest, the more we can work together, the sooner before these problems arise, we can help prevent the problem before it even becomes a problem. And that's why we think that partnering across the continuum, where inpatient works with outpatient, works with long-term care, which works with acute care, everybody working together under the same continuum can really help improve the overall impact of our efforts. Next slide, please.
So let's do a quick case that highlights the importance of coordinated efforts, and then hopefully we'll have at least a few minutes for questions, and we can focus more on the outpatient setting then. So this is a case of a 72-year-old man who was sent back to his long-term care facility after a brief stay at an acute care hospital. His transfer paperwork shows that he's on intravenous vancomycin for a bloodstream infection. This has continued for 4 weeks because it's a bloodstream infection, at which point the patient developed a brain bleed. When his labs were checked, he found to have severely low platelets, presumably a side effect of the vancomycin. The blood culture results had been incomplete at the acute care hospital at the time of transfer. Well, so as it turns out, when the organism was finally identified, it was one typically associated with blood culture contamination rather than infection, and the patient should not have received any further antibiotics after the finalization of that blood culture. So what could have been done differently? Improving communication and coordination. The acute care hospital could have communicated to the long-term care facility the plan regarding the duration of antibiotics and the fact that a pending lab result was going to affect that duration. And a system should have been in place for the hospital to follow up on that culture, even though the patient was no longer in their care, and to communicate with the long-term care facility. So I'll let Shira close us out, and then I think we can take some questions.
Yeah, so, we talked about the importance of working across the continuum of care. Just a reminder, antimicrobial stewardship is not a passive activity. It requires passion, it requires purposeful intervention, and it requires dedicated resources. As patients move through various healthcare settings and from place to place, it becomes really important that we coordinate our efforts to improve the overall quality of care and working together to really multiply the magnitude of our impact. So as I close out, I really encourage all of the participants in today's call to not only collaborate with each other, but to work with other local and regional facilities to align your stewardship strategies and efforts at various points to help optimize the efficacy of your efforts. And with that, we thank you for your time, and we'll open up both the phone lines and the chat box for questions.
And Shira, if you can actually pass the ball back to Morgan, that would be great.
So, we are running a little short on time for questions, so I would encourage everyone to put your questions in chat, because even if we end the webinar, we'll make sure that we get to those questions, and we'll have our speakers address those as well. I guess I would just ask for one quick statement from our speakers as to what would be the first step somebody in an outpatient setting should take to get an antibiotic stewardship program started.
It really, getting the support from the top down, getting buy-in is step one. If you feel like you're trying to start a program and haven't gotten everybody, all your key stakeholders on board, it's gonna be an uphill battle. Whereas getting them engaged and at least in agreement early on will make the process much smoother going forward.
In terms of strategies, I think the place to start is identifying a couple of disease states. One, obviously, to begin with, that you want to attack, and focusing on making sure that the treatment of that disease is guideline-based. So developing a written protocol that all your clinicians can follow, standardizing that practice, measuring whether there was an impact, and feeding back those antibiotic choices back to the providers, if you can, with comparisons to their peers.
Thanks. I really think that's a great place to start, and I think it helps our attendees as well in helping to figure that out. Again, I encourage everybody to please put their questions in chat. We will get to them. I just want to quickly summarize some of the key takeaways from this webinar. First, we know that this is definitely a critical priority. It's become a global issue, and we need to act now. Because success requires a community approach, it's important to engage our outpatient care setting partners. The antibiotic stewardship effort aligns with current requirements for many of our partners, and we kind of mentioned those earlier. And most important, support is available. We encourage you to reach out to the New England QIN-QIO to see how we can assist you in being successful to address this crisis. And thank you for your participation this afternoon. This is a list of the different contacts for the QIN-QIO, and these are the leads in our antibiotic stewardship collaborative, so I encourage you to contact them with any support or efforts that you might need our assistance with. Today's code for CTE Accreditation is core elements. So pharmacists who are looking for CTE Accreditation, that's your code.
Perfect. Thank you, Margie. And as you can see on the screen now, we have a list of all of our upcoming webinars about enhancing medication safety, so be on the lookout for emails about those. Again, we have lots of learning opportunities coming up, so if you're interested in some antibiotic stewardship webinars, you can see those listed on the screen as well. And last but not least, a few closing items. As you can see from this slide, we are now on social media, so please connect with us on Facebook and or LinkedIn for the latest resources, webinars, and other offerings from the New England QIN-QIO. When you close out of this webinar, the evaluation will pop up on your screen, and in there you'll enter that code to make sure you get your certificate of participation or your CEU. And we want to also hear about any programs that you're working on, or if there's any ways that we can support you, so make sure to add that info into your evaluation. If you can't do that right now, or you're sharing a computer with somebody else, you will receive an email tomorrow with a link to the evaluation, as well as a link to the event webpage where you can find the presentation from today, and then the recording and transcript will be added in a few business days. And be on the lookout for more emails coming out about our next webinar on March 28th, covering antibiotic stewardship. So thank you again to all of our speakers for a great presentation. We apologize for some of the technical difficulties that we had, but thanks again, everyone, and have a great day.
The reader has disconnected. The conference will be terminated in 5 minutes.